Good afternoon. Hope everybody's week is off to a good start. My apologies about delaying posting the videos for Happy Hour 7. We were having some technical difficulties. Those have been resolved, and last week's Happy Hour session is posted on the Sagis YouTube channel. The recording of both of our board reviews should also be up on the website tomorrow. For those of you who registered, it is going to be passcode protected, and there will be an email going out, I think later on this evening, that will give you access to all that information. Next week's Happy Hour is going to be hosted by one of my colleagues, Jennifer Vickers. Jennifer is a dermatology-trained dermatopathologist who currently is in practice in Austin. She taught at the UT Derm program for a few years before going into private practice, and currently now does a mixture of both clinical derm and Dermpath. So I know it's a session that you won't want to miss. Then starting in July, at the suggestion of some of the attendees, we're going to start doing the happy hour at 5 p.m. Central rather than 4 p.m. People are getting busy now going back to clinic, and I think that will be a better time for all parties. But again, we'll have an email out to that effect. Today's session was, once again, largely drawn from suggestions that I got from the attendees via either an email to me directly or via the education site. So please keep those suggestions coming, and we'll kind of use them to, we'll incorporate them into each week's menu. Again, if you have any questions at all during this session, I will go ahead and field them offline. You can email me at tdavis@sagisdx.com, or you can call or text. My number is 210-416-4815, or you can always send them to the Sagis Education email, education@sagisdx.com. So any of those will be fine. So without any further hesitation, we'll get started. The first two slides that we'll be discussing, as those of you know who reviewed the sections, are melanocytic lesions. And we've gotten a lot of questions about these two particular entities because there's a lot of histologic overlap. So we'll go ahead and get started. The first biopsy is a pretty large excisional biopsy specimen. Here we are on the trunk, and this was near the buttock. And even at scanning magnification, I think you can see that there's a large but fairly demarcated infiltrative cells in the dermis. I'll go ahead and circle it, extending down into the subcutaneous tissue. And it's got a little bit of a dumbbell configuration, a little bit of a vertical orientation here. And I think even at scan, you begin to pick up that there's some pigment present within this neoplasm. We can see some dark brown to black pigment over at the periphery, and a little bit of variable cellularity. Obviously, we've got this big dumbbell-shaped fascicle here that's pretty highly cellular. Up top, maybe not so many cells. Wipe away my mark. So let's go ahead and zoom in. And on higher power, we can see that these cells, some of them heavily pigmented, are embedded in a somewhat sclerotic stroma. If you look at the collagen between the cells over here in the dermis and compare it with the collagen over at the peripheral portion of the biopsy specimen, note that this collagen's a little thicker and definitely bright pink with kind of a sclerotic appearance. If we look at the cells in the upper portions of the reticular dermis, let's move on in. We can see that we've got these scattered cells, some of which have spindle-shaped nuclei. Some of them are a little bit more fusiform, some are round. They've got a moderate amount of slightly cleared cytoplasm, and many of them contain a little bit of melanin pigment within the cytoplasm. There also is a second population of cells here in the dermis that have a lot of pigment within their cytoplasm, kind of round to oval nuclei with a vesicular chromatin pattern. These are histiocytes. And when we've got histiocytes that contain melanin pigment, we of course refer to those as melanocytes. So we have these melanocytes in the dermis with oval and spindle-shaped nuclei. We have melanophages, and then even in a few areas interspersed between these thickened collagen bundles, we have a few melanocytes that have a slightly more dendritic appearance with kind of compressed, very spindled nuclei and pretty long dendritic processes. And these are kind of not clustered together. I mean, they're short intersecting fascicles, but there's a lot of collagen in this portion of the tumor. And then if we look down deep at this big, large dumbbell-shaped fascicle, we can see we have cells that are a little bit similar in appearance. These have kind of spindled, oval, and fusiform-shaped nuclei and a moderate amount of kind of faintly blue cytoplasm. And these are arranged in fascicles. And when you look at these cells, there's not a lot of nuclear variability. Fairly uniform in size and shape. You know, you can look around in a lot of different areas. We're really not seeing mitotic figures. There's not a lot of necrosis. We do have within this fascicle a lot of clusters of very heavily pigmented melanophages. And of note, particularly down at the base of the biopsy specimen, no inflammatory infiltrate, no mitotic figures, and no necrosis. And this constellation of features is very, very suggestive, really diagnostic of a cellular blue nevus. And cellular blue nevi, you'll remember, tend to have pretty characteristic locations. I mean, you can see them anywhere, but a lot of times we see them on the scalp or on the dorsal hand, and particularly in kids, cellular blue nevi on the buttock, and that's where this particular lesion was from. We obviously have an intradermal lesion. Blue nevi tend to be confined to the dermis. Another characteristic feature here is that sclerotic stroma, which is kind of unique to blue nevi. And we've got dendritic melanocytes present throughout the lesion as well. So those are features which allow one to distinguish in many instances cellular blue nevi from our next entity. So let me pull this down. And we can see here that we have a punch biopsy. This was actually from distal extremity. And we've got a partially sampled melanocytic lesion. You can see that it extends to the edge of the biopsy specimen, but it appears fairly symmetrical. And of note, it's got this V-shaped configuration, almost a little bit of a plexiform pattern. And we have this big nodular aggregate of cells that is similar to the bulbous aggregate we had in the last case, but obviously much more diminutive, much more subtle. Let's zoom on in and take a look at the constituent cells comprising this lesion. And if we look in the dermis, in this particular portion of the specimen, we can see that we've got nests of melanocytes along the dermal epidermal junction, a few solitary melanocytes, and a few small nests along the edges and tips of rete, but there's no particular confluence of cells along the DEJ, not really any upward scatter of melanocytes. And these melanocytes are pretty bland in appearance, pretty banal. A little nuclear variability, but no nuclear hyperchromatism. And there's evidence of note of maturation and depth of these sections. So if we take a look at the size of the nuclei down in the dermis and compare them to the size of the nuclei up top, very uniform in appearance. In addition, the nests tend to break up as we get smaller, as we descend into the dermis, and there are no mitotic figures here. But elsewhere in this lesion, particularly in the deeper reticular dermis and in this area where we saw this plexiform nodule, we have kind of a second population of cells that bear striking similarity to those that we saw in our cellular blue nevus. These also have kind of oval to fusiform nuclei. Some of them are actually a little more epithelioid appearing, but the nuclei are a little bit larger than those in the cellular blue nevus that we saw, and a little more variable in size and shape. In addition, some of them are dusted with melanin pigment. And between these cells, we also have a fair number of melanophages. No mitotic figures, although occasionally you can see a rare mitotic figure in this lesion. And to note the absence of stromal sclerosis here that was so characteristic of a blue nevus. So this is a deep penetrating nevus. And deep penetrating nevi tend to occur in young adults, children. They can occur at any age. They're frequently heavily pigmented. They don't have as characteristic of a distribution as cellular blue nevi. And these, in a very high percentage of cases, are compound lesions. Remember, our blue nevi tend to be dermal melanocytosis. They're confined to the dermis. And the DPNs, not 100% of the time, but very frequently, are compound lesions. In addition, while there is some similar, while they do have some similar cytologic and architectural features of a blue nevi, these lack dendritic melanocytes, and these lesions lack stromal sclerosis. Now, we make these distinctions, and yet there are a fair number of dermatopathologists who feel that deep penetrating nevi are a type of blue nevus. And especially in the case like this, where you have a population of more banal appearing melanocytes, and then this population of more somewhat epithelioid or cellular blue type melanocytes, that this represents a combined nevus, one with features of a banal nevus and a cellular blue nevus. That being said, those are the features that we frequently use to distinguish these two entities. I think for board purposes, if they give you one or the other, they're probably not going to have deep penetrating nevus and cellular blue nevus on the same pick list. There typically is too much histologic similarity, but I wanted to go over some of those distinctions with you. Okay, let's go ahead and move on to slide 3 and another question about these two entities. And these two entities frequently are more confused clinically than they are histologically. So let's go ahead and take slide 3 first. Here we have a bisected punch biopsy. This is from distal extremity. Right away, you know, we can note that the dermis is somewhat fibrotic. We really don't see many adnexal structures. There are a few vertically oriented vessels and a little bit of fibrosis deep. The other thing I think we note right away on scanning magnification is hyperkeratosis and a little bit of epidermal hyperplasia. And hopefully your eye was drawn to the increased number of vessels here within a slightly thickened papillary dermis. And as we go into higher power, we begin to see a lot of tufted or nodular angioplasia, which is frequently seen in the setting of stasis-related vascular change. And so we've got these what have been described as cannonball proliferations of capillaries in a thickened papillary dermis. These are fairly uniform in size and shape, not angulated. They're lined by uniform endothelial cells, kind of congested with RBCs. And while the number is slightly increased, what happens is that the capillaries tend to fold back on one another. They become dilated and tortuous. So when we cut them, when we look at them in a histologic section, it looks like there's an increased number of vessels, whereas there may be one that's just kind of dilated and tortuous, running in and out of the plane of section. Notice also we have dermal fibrosis. We have an infiltrate of lymphocytes here. And unlike the melanin pigment that we've been seeing earlier in macrophages in our pigment and melanocytic lesions, here we have siderophages. And you can see the pigment here is a little bit more golden in color. And within the histiocytes, it's a little more chunky, which is more characteristic of hemosiderin than melanin. And of course, we got extravasated red blood cells. And as I pointed out last week, where there's smoke, there's fire. You know, if you've got a lot of extravasated erythrocytes and a pigment-laden macrophages, 9 times out of 10, you're dealing with hemosiderin rather than melanin. And of course, you could always come in and do a Pearl's iron stain or a Prussian blue to confirm that this was hemosiderin rather than melanin. Quite a bit of dermal fibrosis here, and we've got really bad stasis-related vascular change, and this is characteristic histology that we see in Acroangiodermatitis of Mali, which can present with these red and somewhat raised plaques on the lower extremity in the setting of stasis-related change. Sometimes they can be a little mammillated on the surface, and sometimes clinically they're confused with KS. And sometimes, well, at least in the past, this used to be called pseudo-Kaposi sarcoma, not so much on the basis of histology, but on the basis of the clinical presentation. And this is in direct contradistinction to slide 4, which is a beautiful example of nodular KS. Here we have a punch biopsy also from the lower extremity. We're near an acral surface here. You can tell from the compact quantified layer. And within the dermis, we have this very sharply circumscribed proliferation. And it looks bloody. I mean, you see a lot of erythrocytes, but you also see a high degree of cellularity. And if we move into higher power, we can see lots and lots of spindled cells, kind of arranged in these sweeping fascicles. They're fairly uniform, slightly pleomorphic nuclei, and between the individual fascicles, or between the individual spindle cells comprising the fascicles, in the spaces between, we begin to see individual erythrocytes. And that is a very, very characteristic feature of nodular or plaque stage, late plaque stage KS. And again, the individual erythrocytes between the sweeping fascicles of spindle cells, usually embedded within a somewhat sclerotic stroma. And a point we've made before is you don't get near the degree of cytologic atypia of endothelial cells in KS that you tend to get in classic angiosarcoma. So this is nodular Kaposi, and of course it would be HHV8 positive. And one point to be made for those of you who have not looked at HHV8 stains before, they're a nuclear stain, and it's kind of a touchy stain. So rather than lighting up like a Christmas tree, the nuclear staining in KS tends to be kind of patchy. So if you're ever looking at a stain, it's one that you want to go down and look at high power, because sometimes you may have 30–40% of the cells staining, with 60 to 70% not showing staining, and that is considered a positive stain. Okay, let's go ahead and move on to slide 5. Okay, we got 1, 2, 3, 4. Okay, we're on 5. Okay, 5 and 6 were both lichenoid dermatitis, and if we, let me rotate this. If we take a look, we've got a punch biopsy. This also was from distal extremity. And there's a little bit of compact ortho, a little bit of irregular acanthosis, and this band-like infiltrate obscuring the dermal epidermal junction. Not much extension of the infiltrate into the underlying dermis. So I see this and I always think right away, could this be lichen planus? Because that's kind of my prototype for lichenoid dermatitis. And as we go in, we see it for sure has some features that suggest the possibility of lichen planus. We've got compact ortho and a little wedge-shaped hypergranulosis. And that's kind of across the biopsy specimen. Really not much in the way of parakeratosis here. So that wouldn't be bad for lichen planus. We've got this band-like infiltrate of a lot of lymphocytes obscuring the dermal epidermal junction. We have a few little Max Joseph clefts here, which we can get in really any lichenoid dermatitis. We have a few apoptotic or dyskeratotic cells along the DEJ, not bad for lichen planus. But when we go down and look at the infiltrate, in addition to lymphocytes, we begin to see a fair number of eosinophils. And I don't like to have a large number of eosinophils in my lichen planus. And when I start seeing them pretty readily in the dermis, I'm kind of thinking more about lichenoid drug eruption, which can give you either eosinophils or eosinophils and plasma cells, or sometimes para or clusters of necrotic keratinocytes. But the number of eosinophils here, when you start seeing this many, really think about lichenoid drug eruption. This many eosinophils in idiopathic lichen planus is highly unusual. And this was indeed lichenoid drug eruption. This was a lichenoid drug eruption due to gold in a patient who had rheumatoid arthritis and was being treated with gold. So a lot of histologic similarity to lichen planus. But again, if you begin to see parakeratosis or a lot of plasma cells and eos in the infiltrate, or large collections of necrotic keratinocytes, always think about the possibility of a lichenoid drug eruption. Look at another lichenoid dermatitis with slide 6. Here we have a quadrisected shade biopsy, and we can see a little acanthosis in the central portion of the specimen. And right away, you can tell that the cornified layer is not that compacted. You know, we've got a little bit of basket weave hyperkeratosis, maybe a little bit of compact ortho, especially up here. But as we zoom in, we begin to see, in addition to that, we have a fair amount of parakeratosis. And as expected, right beneath the parakeratotic stratum corneum, the granular layer is markedly thin to absent, which is what we expect below a parakeratotic stratum corneum. There are a lot of necrotic keratinocytes here within the epidermis. We have this patchy band-like infiltrate of lymphocytes and melanophages here, obscuring the dermal epidermal junction. Not as dense as the last lichenoid drug eruption we saw. And if we look over at the periphery, the redi, you can see, are kind of elongated with hyperpigmentation of basilar keratinocytes. And this is a benign lichenoid keratosis, or lichen planus-like keratosis. Very, very commonly biopsy condition. And I think, you know, it's one of these conditions that takes a little bit of clinical experience before you start thinking about the diagnosis. I know when I first started out doing derm residency, I probably, you know, the first 3 or 4 of these I biopsied, I was convinced they were basal cells. And it's only after you biopsy 3 or 4 and get back a BLK that you begin to think, maybe this isn't basal cell, maybe it is a benign lichenoid keratosis. And a lot of times, I think from the viewpoint of pathogenesis, BLKs in most instances are either inflamed lentigines or inflamed seborrheic keratoses. And a lot of times, if you look at the periphery, you know, you might see changes of a lentigo or the architectural pattern, acanthosis and papillomatosis of a seborrheic keratosis. Unlike lichen planus, in a BLK, we tend to see parakeratosis, we tend to see hypogranulosis and hypergranulosis, and a patchy band-like infiltrative lymphocytes and melanophages. Could this be a lichenoid drug eruption? Possibly. Generally, you like to see some EOs, but we've got a lot of necrotic keratinocytes. Could this be a lichenoid photodermatitis? Certainly. The one thing we can say is that this isn't lichen planus. And this brings up the point that when we see a biopsy like this, really, we almost need clinical pathologic correlation. You know, I could be thinking about a lichenoid drug here or a lichenoid photodermatitis, but if the history comes in, you know, rule out basal cell or brown patch or papule or pearly brown papule on the chest, you know it's an isolated lesion and it's likely to be okay. That being said, I've seen a couple of cases where I was ready to sign it out as lichen planus, absolutely classic, with hyperkeratosis, hypergranulosis. I mean, anybody, first-year derm resident will call it lichen planus, and you look at the history, and it's rule out basal cell, isolated lesion on the chest. So while it's good to have these criteria in our minds, I can tell you in real life, sometimes you really need correlation to arrive at a specific diagnosis. You know, I think if they gave you this biopsy on a board exam, they would give you like lichen planus, BLK. They really shouldn't put in lichenoid drug or lichenoid photo. Maybe they could put in lichenoid AK, and there's no atypia here, or DSAP or Potpourri, because that's frequently associated with a lichenoid infiltrate, but there are no cornoid lamella here. So BLK. And I think it's good to look at these lichenoid infiltrates come together. Okay, let's go ahead and move on to slide number 7. Slide number 7, dome-shaped papule. And this is one of these tumors that is like almost immediate pattern diagnosis. And what we have here is almost a cribiform type proliferation, if you will, because these are almost forming, net-like structures. And we've got these narrow anastomosing cords and strands emanating from the undersurface of the epidermis. They're interconnected. They're embedded within an extremely fibromucinous stroma. And what we have, of course, is the pink strands and blue buds that are so characteristic of a fibroepithelial tumor of Pinkus, kind of a low-grade, slow-growing basal cell. And in some areas here, you could even see a little bit of retraction artifact that we expect to see with basal cell, where we get these clefts forming between this lesion and its stroma. And so this was just a really, really pretty example of a fibroepithelial tumor of Pinkus. Okay, let's go ahead and move on to slide 8. Slide 8 was a little bit more tough. We had this particular condition in our recent board review, got a little pushback on it, which I understand it's a difficult diagnosis to make. So we have a trisected shape biopsy specimen here. This is from pretty significantly sun-damaged skin, got the ciliary elastosis in the dermis. And right away you can see a couple of things. One, very sparse perivascular infiltrate. Number 2, kind of irregular acanthosis here. So the epidermis is kind of thinned in this area, but let me get my pencil. If we look here, it's mildly acanthotic. And clearly, we've got hyperkeratosis here. I mean, this cornified layer is almost as thick, if not thicker, than the epidermis. In addition, before we go down too high, take a look at this. We've got a big kind of follicular plug here. Clear that. And let's go on down and take a look at the stratum corneum and the epidermis. A few dilated vessels, but the suprapapillary plates certainly are not thinned. There are lymphocytes here in the dermis. There's para within the stratum corneum with no neutrophils. And notice that the pattern, that the parakeratosis kind of has that checkerboard pattern. So it's kind of alternating vertically and horizontally here in the stratum corneum. And of course, I point out this checkerboard pattern. I talk about follicular plugging and a psoriasiform dermatitis. And, now I'm kind of leading the witness. Where we're going here is PRP. And PRP is a very, very difficult diagnosis to make. And one point that we tried to make in the board exam, I think both Dr. Yalamanchili and myself, take a look over here. And we have a little focus of suprabasilar acantholysis. Not too much disc keratosis here, but suprabasilar acantholysis. And when you see that in a psoriasiform dermatitis with features like this, always think about the possibility of PRP, because this focal acantholysis, it's been written about a lot in the literature. It can be a useful diagnosis for PRP. So PRP is a very, very difficult diagnosis to make. And I can tell you, usually, even after years of experience, it's only the second or third biopsy that I get that I think, oh, could this be PRP? Unless the clinical presentation is absolutely classic, because the findings are really not all that specific. But if there's a strong clinical index of suspicion for PRP, especially if we can correlate with clinical photos, if you see slight epidermal hyperplasia that's not as pronounced as psoriasis, the characteristic staggered mounts of parakeratosis, follicular plugging, and acantholysis, then we tend to be more confident in our diagnosis. And this is actually a more classic example of PRP than the one we showed on the board exam. But I want to let you guys know it can be hard to diagnose clinically, and it can be hard to diagnose histologically. Okay, let's go ahead and move on to slide 9. Slide 9 hopefully was fun for everybody to look at. Kind of hard to figure out where you're at. I mean, subcutaneous tissue, but it's like, where's the epidermis and dermis, and what is this structure? And as you zoomed in on high power, you had to kind of go back to medical school. And when we look at this, we can see a big dilated vessel here. Let me get my pen. And we can see a vascular lumina here containing RBCs. And this is a big muscular artery. Notice that we've got this wreath-like collection of muscularis, and we have an internal elastic membrane here. So this is a pretty good sized artery. And if you looked in areas at the wall of the artery, you could see clearly in a subendothelial zone collections of epithelioid histiocytes. These are multinucleated histiocytes here. Go back and take a look at the slide after we have the discussion. And you can see fragmentation of this internal elastic membrane. And this is very, very characteristic for temporal arteritis. And the reason we have so many cross sections here is the process can be kind of focal and involve the temporal artery in kind of a beaded fashion. So you want to make sure you've got a big enough segment and that it gets cut in cross section, kind of bread loaf, so that you can look at several different segments, because you can get a normal area right next to an abnormal area. And this, of course, is one of our granulomatous vasculitides. But what you want to look for is you want to go down in the area of the internal elastic membrane, subendothelial, and look for collections of histiocytes kind of in the zone of the internal elastic membrane. Okay. I threw in slide 10 and 11 together because they're both conditions in which we tend to have a very uniform dermal proliferation of cells. And so, there aren't that many neoplasms that we see in the skin, where on scan you see very uniform, evenly spaced cells. Neurofibromas, you can see it. Congenital nevi, you can see it. And mast cell disease, you can see it. And so here we have a partially sampled lesion. This is pretty big. It extends to both peripheral edges and kind of focally to the base of the specimen. The surface of the specimen is gently papillated. It's from hair-bearing skin. This was from the trunk. And as we zoom in some areas, we begin to see a lot of pigment here. And, even further in, we begin to see some nested aggregates of melanocytes, either right at the DEJ or just beneath the DEJ in the papillary dermis. The more superficially located melanocytes are pigmented. These cells are very uniform. Notice that they all have round oval nuclei, kind of evenly spaced. They're arranged as cords and strands of cells, no prominent nucleoli, no marked pleomorphism, no mitotic figures, and evidence of maturation with depth. These nuclei are getting smaller as we extend into the dermis, and we're getting more solitary units of melanocytes. In addition, if you noticed in areas, this melanocytic nevus is forming type C melanocytes. It's a neurotized nevus, and a lot of times in older nevi or in very large nevi, you'll get formation of these neural-like tactile structures, and these are just melanocytes kind of showing neural differentiation. And this is a congenital nevus. Notice how deep it extends. And anytime we begin to see melanocytes extending between collagen bundles in the reticular dermis in a band-like fashion, or melanocytes showing annexocentricity or angiocentricity or infiltration of erector pili muscles, especially if they're uniform and evenly spaced, those are very characteristic features of a congenital melanocytic nevus. And so this is nothing more than a congenital melanocytic nevus. And of course, we can verify it with melanocytic stains, S100, SOX. Might stain some of the superficially located nest of melanocytes, but this is congenital melanocytic nevus. And the other entity, and I'm sorry, this was a little bit of a pale stain, but the other entity, it tends to be characterized by very monotonous infiltrate in the skin, is mast cell disease. And here we have a shave biopsy. The epidermis is kind of thinned and effaced. And obviously we've got a subepidermal vesicle here, contains a few cells, maybe some lymphocytes, maybe a few eos, some fibrin. But when we look down at the dermis, we see a population of very uniform cells with round to oval nuclei, very evenly spaced. There's an admixture of eosinophils as well. And I think, the way this was scanned, you couldn't get them real close, but some of these definitely had a fried egg appearance. And when you see a monotonous proliferation of evenly spaced cells in the dermis and begin to see a lot of eosinophils, think about the possibility of mast cell disease. And of course, we could confirm this with mast cell tryptase stain or c-KIT or Giemsa. And remember, mast cell disease, of course, can present with a variety of clinically morphologic lesions and histologically morphologic lesions. So, in bullous mastocytosis, we tend to see dense, diffuse infiltrate of mast cells, frequently with subepidermal vesicle formation, whereas in UP and especially in TMAP, the changes are much more subtle. And sometimes when the infiltrative mast cells in the dermis is not quite as dense, the mast cells can begin to spindle out and look like fibroblasts. And in those instances, you need to have a high index of suspicion and make sure you order your mast cell stains to confirm the diagnosis. But this was just a real nice example of a mastocytoma. And I think you can see the similarity somewhat with congenital nevi. They're both, both fairly monotonous, so they enter into the differential on scanning magnification. And our last case was just kind of a fun case. And again, I'm sorry about the pale stain. This was a case I saw just a few weeks ago. This was a dome-shaped papule on the chest of a 28-year-old. And I forget what the clinical impression was, maybe, keloid or something like that. They certainly didn't think of this entity. And one can see these, we've got a neoplasm here, and it's definitely got a plexiform growth pattern. So we've got a lot of these variably sized fascicles of cells embedded in the dermis, notably absent in the dermis is a proliferation of spindled cells. The dermis is somewhat edematous. And, let's just pick one of these aggregates or fascicles to take a look at. And as you get in, you can see these are pretty highly cellular. They're composed of uniform spindled cells. Some of them have slightly wavy nuclei, but hopefully what you picked up on here were the presence of absolutely beautiful verrucae bodies throughout this lesion. So let's just take a look right here. And you can see these nuclei kind of lining up in parallel rows, and extending their cytoplasmic processes out between the parallel nuclei and forming these kind of acellular tight verrucae bodies. This is a schwannoma that is composed almost entirely of Antoni A tissue. And clinically, these lesions tend to be a little bit more firm. These would, of course, stain with S100 protein and SOX10. We had a schwannoma on the board exam. It wasn't plexiform, but it had a little more Antoni B tissue on it and a little bit of ancient change or nuclear pleomorphism that we sometimes see with degenerating or older schwannomas. Now, a large number of neural tumors can be plexiform. And so we see plexiform change not only in schwannomas, but obviously in neurofibroma. And in a plexiform neurofibroma, you would have similar shaped aggregates, but they wouldn't be as tightly cellular. There would be no verrucae bodies, and you would have evenly spaced spindle cells embedded in a much more myxoid stroma. Furthermore, if you look in the surrounding dermis, these fascicles tend to be just embedded in a background of neurofibroma, which we don't have here. The one tumor that I think you could potentially confuse this with is a plexiform PEN, or palisaded encapsulated neuroma. That's a pretty rare tumor, but some of these aggregates do have the clefts and cracks that we see with the PEN, but I've never seen a PEN or palisaded encapsulated neuroma with verrucae bodies like this. So, but they're benign neural neoplasm. If you mistake one for the other, certainly no harm done to the patient. Some of these patients with plexiform schwannomas do have underlying neurofibromatosis, but a lot of times it can be an isolated finding. It wasn't this person was the only lesion he had. He had no cafe au lait macules or anything, but this is a plexiform schwannoma. Now, the other unique thing about this tumor is it's pretty high up in the dermis, and most schwannomas tend to be deeply located, more commonly in the subcutaneous tissue or in the deeper dermis. This one's a little more superficial, but I just thought it was a real nice example of a plexiform schwannoma. Well, I appreciate everybody's attention. Again, the happy hours should be up to date. You should be getting an email about the recordings for the board exam for those of you who were registered. And next week, Dr. Vickers will be hosting the session, and I'll hop on it and give you an introduction to her. Keep the feedback coming. If there are any entities that you want covered or anything you'd like changed, let us know. And be on the lookout for the announcement that will remind you that starting in July, we're going to have a 5 p.m. Central Standard Time start. I think that will work out better for everybody. Hope everybody has a nice evening. Thank you.